because inherited arrhythmias are one thing, but inherited cardiac conditions cause arrhythmias. So I think that it's important to look at them all together. I don't know what experience you've got in inherited arrhythmias, so just please bear with me. Inherited cardiac conditions, there are several of them. The ones that I deal with mostly are cardiomyopathies, which I'm sure some of you have come across. Hypertrophic cardiomyopathies, incredibly common actually. About 1 in 500 of the UK population has a thickened heart muscle, which could be hypertrophic cardiomyopathy. And more than 50% of those cases are inherited. Dilated cardiomyopathy, about half of them are inherited. And then you have your inherited arrhythmia syndromes, long QT syndrome, Brugada syndrome, catecholinergic polymorphic VT, CPVT, which is a bit rarer, about 1 in 10,000 of the population will suffer from that. Arrhythmogenic right ventricular cardiomyopathy. And then you've got things like connective tissue disorders, Marfan syndrome, and thoracic aneurysm syndrome. You get familial hypercholesterolemia, which can cause an awful lot of premature ischemic heart disease. And then there are lots of conduction disorders which affect the electrical conduction in the heart, and they can be progressive. So why do we carry out family screening for inherited cardiac conditions? My job is to screen first degree relatives of somebody who is affected by either a definite or a possible inherited cardiac condition. Back in the late 1990s and early noughties, it became apparent that more and more people were becoming aware of inherited cardiac conditions. The National Service Framework for Coronary Heart Disease, which was written in the very early noughties, was updated in 2008 with a chapter on arrhythmias and sudden cardiac death. And the reason for that is that most inherited cardiac conditions are passed on within families in an inheritance pattern called autosomal dominant. And for those of you who don't know much about genetics, autosomal means that it does not get inherited via the sex chromosomes. It's usually the gene mutation is on one of the other autosomes, which is one of the chromosomes that doesn't determine gender. And dominant means that you just need one copy of a mutation, a mutated gene, in order to pass it on. So basically what that means is that first degree relatives who share half of that person's genetic information are at 50% risk of carrying a possibly fatal gene mutation, which can cause sudden death. So the Chapter 8 of the National Service Framework gave some rules for what we should be doing for these families. They said that families should be seen in a dedicated clinic with expertise, where they can be managed properly and appropriately, and you can offer counselling and genetic advice. As I've already said, about half of the cardiomyopathies are inherited. That's your dilated cardiomyopathy and hypertrophic cardiomyopathy. Channelopathies, which are the inherited arrhythmias, long QT and Brugada, and ARVC, which is the right ventricular cardiomyopathy, are always inherited. We know that if you screen first degree relatives, you can save lives. That's what we do. We also know that early detection of cardiomyopathies can decrease severity, and it also increases treatment options. So it allows us to treat a very minor condition rather than somebody gradually over many years developing a cardiomyopathy, which suddenly causes them to crash and burn, and can make them very, very unwell. By carrying out family screening and carrying out genetic testing in some cases, we can decrease uncertainty for people. If you have somebody in the family who's dropped down dead, somebody who has been diagnosed with one of these conditions, it can cause a great tsunami of anxiety within a family. And so carrying out screening of people can sometimes give them the reassurance that actually everything looks okay. It's unlikely you're going to drop down dead, and hopefully we can give them that reassurance. If we find that they have the condition, then we can reduce the risk by giving them medications, providing them with defibrillators if necessary. Inherited cardiac conditions do affect all ages, but disproportionately to young people. this picture of all the young people in a red t-shirt, they're all members of the Cardiomyopathy UK charity young persons panel, and they get involved in all sorts of policy decisions, and they help organisations like NHS England. They give advice, they carry out focus groups so that the right support can be given to young people. The young guy lying down with his mum's hand on his head is a patient of mine called Scott, who, when he was 21 and at Oxford University, was at the gym and just collapsed, had a cardiac arrest, and luckily they had a defibrillator. He survived. He woke up in hospital with his mum and dad there, who dashed down from the northeast, and he didn't know what had happened. Luckily, he survived. He's okay. He's neurologically intact. And we are now carrying out genetic testing within him, and we're screening his relatives. And the lady with the 3 children on the right here is a lady called Nicola, who has long QT syndrome, which was found after, sadly, her sister dropped down dead. She was in the middle of a phone call with her, went quiet. She went dashing around there and found her sister collapsed with the phone still in her hand. Tragic. That's often the first symptom of inherited cardiac conditions. Since then, she's been found to have long QT syndrome, and her 3 children are undergoing predictive testing. So hopefully we can save their lives. The Cardiac Family History Service, I started working in inherited cardiac conditions after a long and very mixed career, but lots of it in cardiology in Newcastle and down in London before that. The Cardiac Family History Service was set up in 2009. It's a regional service that covers the whole of the North region, which is from Middlesbrough and down to North Yorkshire in the south, right up to Berwick upon Tweed, the borders, and across to North Cumbria. There are 3 cardiac genetics nurses who are based at Sunderland, Middlesbrough and Newcastle. And I'm the one who's at Newcastle. So cardiac genetics nurses, what do we do? Please forgive this, but I thought it was quite good. I often describe cardiac genetics nurses to patients and families as clinical detectives. So a bit like Sherlock Holmes, but without the deer stalker. What we support, we investigate families for possible inherited cardiac conditions. We provide counselling, information. We draw family pedigrees so we can identify people who might be at risk. We organise and we carry out investigations, clinical investigations, so echoes, ECGs, sometimes exercise tests, 24-hour tapes, and we advise about the implications of inherited cardiac conditions. Phenotyping is important. So a genotype is a genetic roadmap, if you like. It tells us what the genes are in that person and whether or not they have an abnormality in them. And the phenotype is how does that present in somebody. It's really important to get detailed information about how people are within families, because some inherited cardiac conditions can present in different ways within the same family. So it's very important to get that phenotyping right, because it gives us clues as to which gene alterations to look out for. We talk about the signs and inheritance patterns with families and answer their questions about risk. And we work out the probability of inherited cardiac disease within these families, whether that be cardiomyopathies, inherited arrhythmias, or in sudden death families. We see families of people who have dropped down dead suddenly when they come to light, when they're given the right advice, either by charities such as CRY, Cardiac Risk in the Young, SADS, which is Sudden Adult Death Syndrome Society, British Heart Foundation, Cardiomyopathy UK, and hopefully pathologists and coroners will signpost people to say this could be a risk to other family members. Sometimes there is no family history whatsoever of any heart disease within the family, and the first symptom, sadly, is sudden death. This is just a slide just to show you how busy we've got from starting the service in 2009 up to 2020. Did crash a little bit this time last year and throughout the year, but it started to build up again. And this is just to show you what sort of referrals I've had at the Cardiac Family History Service Clinic at Freeman Hospital in Newcastle in 2019. You can see that the majority are cardiomyopathies, and the rest are a smattering of inherited arrhythmias largely. Sudden cardiac deaths are normally caused by an inherited arrhythmia when there's no other apparent cause. However, if we look at sudden cardiac deaths in the UK right across the board, there are actually about 100,000 of them a year. Most of them are down to coronary heart disease, ischemic heart disease. So it's wear and tear, build up of plaque within coronary arteries that causes people to die, or sometimes within other parts of the body, such as the brain, which causes stroke. There are about 500 unexplained deaths in the UK each year. So what that means is the heart at post-mortem is structurally normal. There's no sign of a heart muscle problem, a cardiomyopathy. There's no sign of an MI, an infarct. Toxicology is normal, so they haven't taken an overdose. There's nothing there that's poisoned them. And when you take all of that into account, and there's no other explanation, quite often the post-mortem report will put cause of death as unascertained, and that means that there is sudden arrhythmic death syndrome, the SADS case. Many of these are young adults and teenagers. And the important thing to remember, which I've already said, is that 50% of their relatives could be at risk of sudden cardiac death. In the northern region, there are about 50 sudden cardiac deaths annually. Some of these are down to ischemic heart disease, and some of the young people die because they have an inherited form of high cholesterol. So they have a familial hypercholesterolemia, which has got a very definite diagnosis. And if you come across anybody who seems to have a lot of people having heart attacks in their family, might be worth asking, has anybody had their cholesterol checked? Because it's so treatable. Put somebody onto statins and you reduce the risk right down. Other young sudden cardiac deaths can be down to aortic dissection. That can be because people have got an inherited connective tissue disorder, and familial thoracic aortic aneurysm. You then have the group of people who die suddenly who at post-mortem have a cardiomyopathy. And the ones that haven't are the SADS deaths that we've already mentioned: Brugada syndrome, long QT, CPVT, and PCCD, which is progressive cardiac conduction disease. I thought I'd just very briefly go through what some of these things are, because you may or may not have heard about them. And if you're interested, there's lots of places you can look. Cardiomyopathy UK charity website, which is largely for patients, has got an awful lot of information for healthcare professionals as well. There's some really good information on there if you don't know much about cardiomyopathy. Hypertrophic cardiomyopathy can be present from birth, but usually it doesn't develop until later. Interestingly, I think, and quite sadly, children and infants who are born with hypertrophic cardiomyopathy are often very, very unwell, whereas a lot of the people that I come across, it's developed over time, and people can present anywhere from their teens up to their 60s or 70s. When it's inherited, it usually presents a bit earlier, but it can present at any time. Normally, it's passed on in an autosomal dominant fashion. So that means that relatives, first degree relatives, have a 50% chance of being at risk. And it can present in a variety of ways. People can be short of breath. They can be generally just going downhill, if you like, and gradually just getting a bit worse and less able. They can have chest pain. Sometimes they present with palpitations or syncope. And as I've already said, sadly, sometimes with sudden death. It's usually when we have a look at it on MRI or echo, instead of having a nice even wall thickness, the septum between the left and right ventricles is very often asymmetrically thickened compared to the outer walls, but you can get concentric thickening all the way around, and it can cause either a reduced heart function, so they can present with heart failure symptoms, or you can get electrical disturbances because they have myocardial or myocyte disarray or fibrosis. And that's where the cells, if you think of the, I don't know if you can see me in the bottom of your screen, but if you think of the heart muscle cells as all being lined up like that, in myocardial disarray or myocyte disarray, the heart muscle cells are kind of higgledy-piggledy, like interlocking your fingers, and that can cause electrical disorders of the heart, arrhythmias. Dilated cardiomyopathy can present in very similar ways, but as you can see on this picture, the left ventricle usually, but sometimes both ventricles, get stretched. I guess the best way to think about it is a bit like an overstretched balloon. If you take a new balloon out of the packet, you've all been there at kiddies' parties. It's really difficult to blow up and you have to stretch it a little bit, haven't you? But once you've blown it up, if you hold it at the neck and you put your other hand around the ball of the balloon, it's quite firm. It's got a lot of elastic in the walls. And when you let go of the neck of the balloon, the air rushes out and it can fly around the room. And that's quite a good analogy for what the normal ventricle should be like. The walls are nice and firm. They've got a lot of elastic in them. They bounce backwards and forwards and they cause a good pumping action. In dilated cardiomyopathy, it's like taking that balloon and blowing it up 10 times so that when you give it a squeeze, it's a little bit saggy, if you like, hasn't got the oomph in it, so that when you let go of the neck of the balloon, the air comes out very slowly because it hasn't got that elasticity in the walls. And I think that's a really good analogy for what happens in the ventricles of somebody who has a dilated cardiomyopathy. I commonly see adults who've got a big left ventricle with a reduced function, but quite often we get biventricular involvement, and sometimes the atria are really stretched as well, and this can cause a lot of atrial arrhythmias as well as ventricular arrhythmias and heart block. Sometimes they present with clots, chest pain, murmurs, and again, sudden death. ARVC, or arrhythmogenic right ventricular cardiomyopathy. This affects principally, but not exclusively, the right ventricle. It's a progressive disease which can start at, well, in children, sort of once they get to double figures, we're more likely to see it, although it is rarely seen in younger children. And it can cause a progressive loss of the ventricular tissue, and the heart muscle gets replaced by fatty replacement in between the heart muscle cells. It can generate areas of electrical instability, and it can cause ventricular tachycardia or ventricular fibrillation. Okay, I know this is a whistle-stop tour, but I am very aware we haven't got an awful lot of time. Long QT syndrome is what we call a channelopathy. It is an electrical disorder which is inherited. It affects the channels, the ion channels in the cell membranes, which open up and close again to let the charged particles, the sodium, potassium, magnesium, calcium, go across the cell membrane. And it's those ions moving with an electrical charge that causes an electrical current that goes down through the heart. When you have a problem with the genes that affect these channels, it can either make them stay open for too long or make them close too quickly. And depending on which channels they are, particularly the potassium and sodium channels get affected, it can cause the potential to have electrical disturbances, which can cause VT, ventricular tachycardia. Long QT syndrome is largely down to potassium channels staying open for too long, and sometimes the sodium channels. And what it does is it causes a longer repolarization in the heart muscle cells. So you get the ions that go across the channels, which causes depolarization of the cells, and then you get them reversing, which causes repolarization. And in long QT syndrome, it takes longer for repolarization, which means that the heart muscle cells are in a more unstable state for longer than they should be, so that if the next signal comes along, it can cause irritability of the cells and trigger a ventricular arrhythmia. It can cause blackouts, palpitations, seizures, and sudden death. I'm not going to go through this, we haven't got time, but we measure the QT interval on the ECG and then we correct it for heart rate. Because obviously if you've got a very slow heart rate and you look at an ECG, it's going to look a bit more elongated. So you have to take heart rate into account. And this is Bazet's formula, which is what a lot of the cardiologists use. You don't need to know that unless you're doing it on a daily basis. And this just shows you that there are different types of long QT syndrome. Long QT1 and long QT2 are potassium channelopathies, and long QT3 is a sodium channelopathy. Sometimes the ECG has a slightly different morphology, but again, you don't need to worry about that. There are some management and clinical management and lifestyle issues associated with the different types. So quite often, but not exclusively, type 1 long QT can be syncope and cardiac arrest can be triggered by swimming in cold water or exercise. Type 2 can sometimes be caused, people can have syncope caused by loud noises, the startle reflex, sudden arousal. And I have actually come across a family where one lady collapsed every time there was a loud noise, and she actually had a cardiac arrest when she was having an argument with a neighbour, and she went in and banged the door shut, and that was enough to make her go down. Type 3 long QT is much more often associated with people dying in their sleep or having syncope in their sleep, having fits, having abnormal breathing, agonal breathing in their sleep, and it often wakes up partners, and sometimes shaking them will actually wake them up and they come out of it. There are medicines to avoid. We know that these channelopathies can be affected by certain medications, and some of them are quite common. So, for instance, things like erythromycin and some antihistamines, some antifungal medicines will cause the QT interval to be prolonged. The longer the QT interval, the more likely it is somebody will have a ventricular arrhythmia. So we advise people to avoid medicines that can prolong the QT interval. And this website, crediblemeds.org, is the best place to direct people to, because it's updated on a regular basis. They have an app people can put onto their smartphone. So if they're checking a new medication, they can have a look on there. Now, it's not the patient's responsibility, obviously, to say, I can't take that. It's the medical practitioner who's actually prescribing it. However, we can't remember everything, and it's good to let patients know that they can check out ingredients, particularly for over-the-counter medications, things like cough medicines, that sort of thing. We advise people to avoid excessive alcohol and recreational drugs, and that's because they can affect the blood chemistry. And if the blood chemistry isn't right, because the electrical conduction system in the heart relies on the blood chemistry, that can make them more at risk. We tell them to rehydrate safely. So if they have a tummy disturbance, if they've got diarrhea and vomiting, or if they're in a country where they're sweating excessively, they might become dehydrated. We give them advice to rehydrate using rehydration salts like diaurolite. We often give them beta blockers because beta blockers can reduce the risk of arrhythmia. It won't reduce the length of the QT interval, but it makes the heart less irritable and therefore less likely to have an arrhythmia. You have to be careful with type 3 because if you slow the heart rate down in type 3 long QT syndrome, you're more likely to cause an arrhythmia. So sometimes if people are very affected and they've got type 3 long QT syndrome, we put a pacemaker into them, we put a minimum heart rate on there, and we also give them a beta blocker. That's just what it can look like if you do an ECG when somebody's having ventricular tachycardia, and it's not very pretty, and you don't get much of a cardiac output from that. And this is a family with long QT syndrome. I just wanted to show you, this was the first person, FM, that I saw with long QT. She didn't do much about family screening. She told me her dad had died at 60. And then some other family members came to me after the little girl, RN here, Ruby, had a collapse following swimming. Turned out it was the same family when I spoke to them. We did genetic testing, found out that this little girl had type 2 long QT. We tested her brothers, they had it. Mum had it. Her twin brother had it. The original sister had it, and her children all had it. So hopefully they're all on beta blockers now, and hopefully they won't have any collapses. Now I'm very short of time, so just to let you know, one of the other channelopathies is Brugada syndrome. It's very like long QT type 3. It's a sodium channel problem, and it can often cause sudden death in sleep. Used to be put down quite often to silent pneumonia when young people died in their beds. Mostly it's Brugada syndrome. It's got a typical looking ECG, but you don't always find that without trying to unmask it with either drugs or by moving the leads on the ECG machine. CPVT, catecholinergic polymorph, catecholinergic polymorphic VT. Basically, the message to take away from that is that it is associated with high levels of adrenaline. Or catechole means flood in the system. People, when they're excited, when they're scared, sometimes when they exercise, when they're emotional. One lady, whenever she had an argument, apparently collapsed, and people can have syncope, blackouts, and actually die in the middle of an argument. That's what it looks like. And I think that's probably time up. So I'm going to call that to an end. I think the main message is think genetics. If you come across somebody and you think that this could be inherited, but you don't know, get in touch with somebody who does know. They can give you some advice and refer you to the right place. I'm always happy to give advice. That's my contact details. And I'm sure if you're from another area, there'll be people in your area you can turn to as well. I'll take a breath.
Wow, Julie, that was impressive for 30 minutes and so informative. Thank you so much.
Right.
Very, very interesting stuff and a little bit terrifying, I'm not going to lie. But thankfully, we've got people like you keeping us and looking us all up. Is there any questions from the audience? I've recorded this session, Julie, so if it's okay with you, I'd like to pop it onto the network website.
Yes, that's fine.
Is that okay? That's brilliant. Thank you. So if there's nothing from our colleagues who've joined us, I'll say thank you once again to Julie. That was absolutely outstanding. Thank you very much. And we look forward to seeing everybody again when we rerun the boosters later in the year.
You're welcome. Anytime.
Take care, everybody. Thanks a lot.
Bye.
Bye. Thank you. Bye-bye.